Good afternoon, everyone. Uh, so sorry, Vishwajit, I didn't add your name because, yeah. That's right. So that's it. So we will be discussing the second line options in gastric cancer, and definitely it's advanced gastric cancer. So, so it's a case which we'll deep dive into, and there are quite few senior persons here in the in sitting down there. I can ask them to contribute wherever they feel they can contribute. So we have a 57 years old diagnosed case of advanced gastric cancer. There was no bleed, no obstruction, 2 to 3 liver deposits, ascitic fluid was positive, adenocarcinoma grade 2. So if I can come down to, let's say, Biswajit, what exactly would you want? It's a second line, I understand the panel, but before you start off any case of advanced gastric cancer, finances not being a hurdle to you, what would be what do you want on your table to be there before you even plan your treatment?
The first thing would be the performance status and the nutrition, most
the clinical
important.
parts apart.
After that, the biopsy for some few molecular tests. One would be the MSI testing.
Okay.
And then the PDL1 testing, HER2 testing.
So you want MSI testing or MMR to be done, you want PDL1 testing, and you want a HER2 new testing.
I would start with HER2 first.
That's it. Anyone in the panel wants something different? Viraj? No? Okay. 3 things. So PDL1 CPS is okay. Tumor inhibition burden, you speak quite a few times. You've spoken of tumor inhibition burden, GI cancer. Day 1 or any time in your practice, do you want that?
Yeah.
Can I have one more mic, please?
So day 1, I agree with Dr. Biswajit.
Okay.
MMR, PDL1, HER2, and when they progress, we all do NGS if they can afford,
Okay.
specifically to look at TMB and other like FGFRs or EGFR pathway.
Okay. So now we move down to NGS. If I can go to Jitin. Second line. So in the first line, people want HER2 new. All expected, we want HER2 new. We want MSI to be done. We want a CPS or PDL1, however you name it. And NGS in the second line. Why exactly he spoke of few things? So what exactly would you want in
TMB,
NGS?
maybe NTRK.
NTRK.
Maybe NTRK. One is, if others rare mutation, but they are very less likely to happen. Although NTRK itself is very rare.
Okay. Anyone in the, you do NGS in the second line only, or first line also you would like to do NGS? Randeep or anyone? Second line alone? Nothing in the first line. Yeah, that's fine.
I would like first line, but we don't do it first line.
Okay, you would like to do first line. Okay. So this is the data from the TOGA trial, and this is something which I understand. I don't know how important it is. What caught my attention in the paper was around 20% of patients of IHC 0 and 1 were positive on FISH. So 20% is not a number which can be discarded. So in the simple question is, if this is such a high number, do you want us to do IHC first, and if only 2+, then go the FISH way, or can we go directly for a FISH? Because very unlikely you will miss a FISH positivity or FISH negativity. It's less than 2 to 3% in a IHC 3+. So anyone can take it. Nikhil, what is your take on it? I would just, this is an article well published in 2009-10. It's not a data which I want to push for, just a simple thing which I thought should be discussed in the panel because this has its importance. Please tell. Nikhil, what is your thought on this?
Say 2 things. One is the IHC.
Can you speak into the mic, please? Yeah.
So IHC 2+, also many may be FISH positive, which
We need, anyway 2+, I would do a FISH. That's the way. And 0 and 1, we don't do FISH. What my point is the data of 0 to 1, which constitutes around 20 to 25% of the persons who are negative otherwise are positive by FISH. And this is from the largest data set which you have on the first line HER2 new positive. Anyone?
Yeah. So if you see the subset analysis of TOGA, 3+ gets the maximum benefit, 18 months. 2+ with FISH positive is second best. It's not even close to 3+. So what I gather is FISH comes second, IHC trumps over everything as far as HER2 testing is concerned. So I would not do FISH for 0 and 1 because I know they are not going to do well on trastuzumab, which is what was there in TOGA also.
Okay, this is a fair point. In that data, this is what I wanted to, because the data will look like this, but when they analyze the data, they looked at 0 to 1, the fish, they did benefit that over the standard of care. The benefit was very marginal. The highest benefit was either 2 plus with fish or a 3 plus. So this is the data which I felt is little different from breast cancer. In breast cancer, Amit, is it this, that 0 to 1 are so many fish positives or little lesser? In the breast cancer scenario, do we find a fish positive around 20 to 20% in the 0 and 1 IHC group?
I don't get
don't
fish
test
done
only.
in 0 1.
We don't test.
We don't.
I don't get 0 1 fish test done.
No, but now what's the data like?
But I think it's about 2-3%
Okay.
or so.
So this is
It's
the
very
point I
tiny.
wanted to highlight. It's very contrast to what we see in breast cancer. That's the only point I want to highlight. But this was central lab. These the toga, everything.
Yeah, so I think the more important point is that your pathologist should be aware of how to do it.
Yeah, no,
So-
this was the central lab data.
I think what Senthil wants to make a point is the HER2, I mean the lab, if the pathologist knows that they are doing a HER2 for breast or GI, I mean,
The differences
that
should
is
be
the
there.
point, the way they interpret it
Yeah.
and the way they put it 3 plus is.
So what the staining, the staining and the point the point people are making out here is the IHC, the pattern of the staining in a stomach versus breast is very different. The lateral and the posterolateral staining is there. There is the intensities. So that's for a biopsy, small versus the histopath. For a biopsy, you need 5 to 6 cancer cells cluster. On a histopath, you need the sample is there. So that's why biopsies are probably more positive for HER2 neu because the cluster is much limited. So that is also data from TOGA. Okay, we move on now. So HER2 neu 3 plus on IHC, PDL1 15%. That's the CPS score. Let's say CPS score 15%. Quick one-liner because it's the first line. What would be your treatment of choice? Please.
Folfox and trastuzumab is my treatment of choice. Till
Okay.
first line immunotherapy, maybe I'll keep it in reserve. Immunotherapy.
You will keep it in reserve. Vishwajit, does the 811 strike a thing that I will go ahead and do something?
Uh, the problem with the PDL1 is in the second line you don't have
You can speak into the mic.
the
Yeah, please. It is working. Yeah.
second line data for immunotherapy.
First
is
line.
an issue.
Your first line.
Yeah. So it's a very difficult situation. I would, if the cost is not a factor, I would do the immunotherapy first.
You
and
would
not
like
the
to
HER2.
do the combination with trastuzumab and pembrolizumab.
That is an option.
Okay.
But
You're,
other-
Viraj, you're convinced of the data? 811?
Keynote 811.
Okay. So I'll just skip this because I think the things are changing. We have also got an approval, although on interim analysis that has to be put forward. We would like to see the full analysis to be done. But on the basis, the responses are much, much superior. That's something we all agree, and that has been the data. So now this patient did not receive immunotherapy, received chemotherapy with trastuzumab, responded with a partial response, progressed after 11 months. So what next? We all believe that we did a NGS at this point of time, and it did not show the NTRK positive. That was not there. So now, what would you do? Please, Nikhil.
Sir, is there a possibility of rebiopsy and getting the HER2 checked again? Because all
Okay.
the trials which said that this when the TDM1 which didn't benefit or trastuzumab beyond progression didn't benefit, did not actually rebiopsy and they did not check out whether that HER2 had, which was initially positive, whether it turned negative or not.
So is it coming out that if there is a you'll rebiopsy, if it is negative, the person would not be eligible for a Destiny 101 like trial? Because if you do a biopsy, you have a negativity thing, then you're implying to the patient from day one that you would not offer the patient deruxtecan. So,
So
if,
Destiny came much later.
so now
possibly, yeah.
we are in the era where the trial is there.
Destiny is there.
So what would be your choice? Please. Anyone.
Destiny will be the best way to go ahead.
So that
If
would be
MSI,
your-
everything is
Pinaki?
negative.
Viraj, you?
No, I would like to biopsy. If it is negative, I have my doubts whether TDXD would work at all.
So you would not do.
I would like to do a biopsy.
If it is negative, you would not offer the
No
patient.
HER2 targeting.
Okay. Everyone of the same thinking?
If rebiopsy.
All of the same thinking there also? Yeah, please. Can you speak into the mic? Yeah, please, no.
So if you look at what happened in the Destiny, only 30% had a rebiopsy. 70% did not have a rebiopsy. The benefit of TDXT was similar whether you had a biopsy or not. Logically, what Viraj says is absolutely taken, but the Destiny did not show this. So the Destiny of TDXT was decided not based on a biopsy.
So,
Can I
yeah,
add one
please.
point, sir?
Please.
Sir, in that, what IHC HER2 suggests, if you are taking small biopsy, you should at least do check minimum 5 biopsy for that sample for HER2. This is what.
Though the statement is you should have a cluster of 5 to 7 cancer cells.
No,
That
sir,
is
it is in the individual sample to be taken for, and you should take small biopsy. There should be multiple biopsy should be taken.
I don't
Ideally
think so. I don't think so. I'm pretty
This
clear
is
about
this
this.
is coming up.
Yeah, please.
So one comment, very well made, sir. So if we know HER2 amplification is picked up more on liquid rather than tissue because it is heterogeneous. So even in colon, if you see HER2 amplification after anti-GFR is only 2 to 3% if you do biopsy, while goes high up to 8 to 10% if you do a liquid biopsy.
Yes.
And the reason why the not done biopsy TDXD benefited, I would guess, is perhaps they have some HER2 amplified clones in their plasma.
Correct. So ultimately, I think something like a, a
But then I
nucleus-
would do HER2 testing by liquid and prove
Correct.
it that it is amplified to continue HER2 targeting.
Point well.
Okay, so I will put the things into perspective. At this point, there is nothing to choose your treatment based on the second biopsy. If it's a negative, I think it is a prerogative to even discuss that patient. As per the trial, as per the evidence, I think that option is eligible for the patient, eligible for the option. That's what I would take home and make that message very clear. The subset clearly did not show what the panel is suggesting, but there is a difference of opinion. Few of the panelists strongly agree that if it is negative, they would not be very much interested in the second line HER2 targeted therapy. That's the impression, but I feel the Destiny showed us that it was one of the drug which showed the OS and the PFS benefit, and the hazards was around 6.6. So that is something that was never seen till now, and that's how it should be. And even look at the partial response in CRs, it was around 40% of a response rate, and that is something second line looks very good. So this patient, HER2 neu negative, failed capox first line. Now we're changing the things. We're taking out the HER2 neu positive part because then the discussion for the next 10 to 15 minutes will be on this. The CPS is 15%. I keep the CPS score the same. Patient has progressed to capox chemotherapy in the first line which was given to them. So Vishwajit, you spoke of OS to be one of the criteria on which you choose your second line. What could be the other criteria which you consider before choosing second line?
So,
Sorry, performance status. Performance
yeah.
status, sorry.
Okay. So obviously performance status, toxicity and survival. These are the three
Toxicity.
things.
What exactly would you look into the toxicity, and how would that change your second line management?
So the first is survival. I mean, in order wise, it has to be survival, and then toxicity in terms of cytotoxic. I mean, neuropathy is the most important.
Okay, so you have brought in neuropathy. I'll come to that. If there's a neuropathy, because most of our patients have taken docetaxel, and there could be a taxane or paclitaxel, there could be neuropathy pre-existing when they come to second line. How do you manage that will be an important point in second line, that I'll discuss that. Anything, Nikhil, you want to add to that? Pre-existing toxicity which continues a patient, the performance status are the two things. Probably the CPS score would matter at this point, which are already there with you. Okay. Now with that things, what is your second line? Can you choose for this patient who's HER2 neu negative, has failed capox, and around 11 months after the failure of capox, what would be your drug of choice? With the patient of CPS 15, performance status fairly good, having a grade 2/3 peripheral neuropathy.
Grade 2/3
Peripheral neuropathy. Anyone else? Yeah, please.
Ramucirumab with Folfiri is
Everything what I have told here are approved agents. So what would be your choice? Yeah, I'll come down.
Ramucirumab with Folfiri would be one of
So ramucirumab with Folfiri would be one of your choices which you would go for that. Okay, Pinaki?
Yeah, I think another is Folfiri with Pembro. Because
Folfiri with Pembro. Do you have any data to back it up in second line of a chemotherapy with immune checkpoints?
No, sir.
No. But you would still
But
go for it because
or
of
irinotecan with
the
flow.
CPS score has tempted you to go for
Or
that.
irinotecan with
Fair enough, we'll come to that. Please, Jiten.
Irinotecan plus ramucirumab.
Irinotecan plus ramucirumab. Viraj?
Yes, we do IRI plus ramucirumab if neuropathy is significant, otherwise taxane plus neuropathy.
Okay. Vishwajit, you wanted to say something here.
I will just do fall free. Ramucirumab, the data for that Rainbow Asia study is negative, so not sure whether really the benefit of ramucirumab is there. In the Rainbow first trial, there was benefit. The second trial in Asian population, I'm not sure. There was a data
You're not
which
sure.
is not
So-
shown, but otherwise there is that regard trial where they've used single agent ramucirumab, that's an option. Pembrolizumab definitely no, because there is, in adenocarcinomas there is no benefit. Squamous there was a benefit with. So
We'll
out
come down
of
to that,
label
and I hope you change your mind
option.
at some point.
Okay.
Maybe third line you would consider that in such patients.
But at this point of time,
Okay.
I just do cytotoxic with fall free.
So for you, it is it is ramucirumab with. You will just go with chemotherapy alone, and that will be folfiri for you. Perfect. So we have one folfiri, we have a ramucirumab with folfiri, we have ramucirumab with irinotecan, we have pembro with chemotherapy. Fair enough. And we have one more. Okay. So one statement is done that the panelists univocally told that there is no taxanes because of pre-existing neuropathy. Viraj told if there is no neuropathy, he would go with a VEGF inhibitor with a taxane. That would be his choice. I think the chemotherapy alone, there are 2-3 things which I wanted to point out for chemotherapy alone. If it has been a patient who has failed, let's say, docetaxel based chemotherapy with a platinum, what would be your treatment of choice in such case? There is no hardcore level 1 evidence. There is some data from a short trial. Would you point towards that and tell me something which is there for patients pre-docetaxel exposed and not exposed? Vishwajit, anything like that? Okay, fair enough. So I think the NCC and all of us know that these are the agents, and that's what the panel spoke about. This is the regard trial which Vishwa mentioned, the single ramucirumab. The worrying thing for single ramucirumab for me, like Pinaki, where would you even offer a single ramucirumab in today's date? Which are the patient? Can you select a patient, you or Jiten, anyone can come in with that?
Any patient means who to first line who has not tolerated chemotherapy well.
First line?
Means if first line chemotherapy was
GC is not
tolerated
good
well,
enough.
GC is
That's
not
your
good
point?
enough.
Okay.
Otherwise means
Okay. So what I meant was, if you look at it, the progressions are little too high to a comfort with single ramucirumab. And the overall survival was around 5 months. And the responses were not too great. Most of them stable disease. You would occasionally get even a partial response. And that is one thing about the regard trial, but it was better than placebo, not doing nothing. And this, all of us know what it is. I was speaking of the response rate is actually less than 3 to 4%. And the progressive disease, around 1/3 of the patient progressed on ramucirumab, as expectedly. The rainbow is what is published is paclitaxel with ramucirumab or paclitaxel alone. And this has the difference is, that is why I think Viraj told that if no neuropathy, he'll go for that because the responses are a good 30%. And the stability is a good around 50%. So 80% would respond. The third thing is that ramucirumab with irinotecan, I think Viraj, you picked it up. There is no hard level data for that. But yes, the responses are around 25 with a stability of 80%. And that is as good as you saw with Pacli and ramucirumab. This is the data which is from a very short trial, the RAM-IRIS trial. This data showed one thing, that if patient is docetaxel pre-exposed, I don't draw conclusions, it's for you to take this data up. If the response rate were 25% for FOLFIRI with ramucirumab versus Pacli with ramucirumab, and the response of 25 versus 8%, and the PFS was again superior, the OS was numerically better. In contrast, for the all patient who received or did not receive docetaxel, it was equivalent. So what this data points out to me is not the level 1 of evidence, but if you are pre-exposed to docetaxel, it is better to use probably a FOLFIRI with ramucirumab and irinotecan ramucirumab. Anyone has used ramucirumab FOLFIRI as a combination second line? And what has been experienced with toxicity?
It's very well tolerated.
Very well tolerated. And that's the data what it is, because all of us have feared FOLFIRI as a protocol, but this data, irrespective of trials, multiple have shown, it is a combination that has been producing lesser side effects. Okay, so we move on. This was the conclusion for this trial. it demonstrated feasibility of combination of FOLFIRI with RAM. Dosi pre-treated patients seem to derive pronounced benefit with FOLFIRI. And that's, I thought, is something, yeah, please, you want to say, Nikhil.
I think by mistake it has been written folfoxin.
Oh, sorry. My mistake. Okay. So, anyone wants to speak about keynote 059 in this second or third line of therapies? Viraj, in the third line for this patient, if has failed ramucirumab and let's say FOLFIRI, as most of the panel, or FOLFIRI for you, Vishwajit, would you consider, Vishwajit, coming to you first because you told no immune checkpoints. So would you consider a 059 like of thing for a pembrolizumab single agent, gastric G junction adenocarcinoma?
So there was the subset analysis of CPS more than 10, which
Yeah.
showed some benefit.
Yeah.
But again, when they included both adeno and squamous, and the benefit was more in the squamous, actually the adeno did not show.
Okay.
So it's an off-label indication, you could still use it.
Would you use nivolumab?
Again,
Because there is a data for nivolumab in this line more than beyond 2 lines.
again, not sure in adenocarcinoma.
Not
Again,
sure.
all of them are in
Okay,
squamous.
we'll see
so
that.
off-label indication.
Can I go across, Nikhil? Third line, patient failed failed 2 lines of therapy, one with ramucirumab. Would you consider 15% CPS a immune checkpoint?
Only because I'm up against the wall.
Only because?
I'm up against a wall. There
Okay. Only because you're up against the wall, you're not convinced about the data. Okay.
I will consider, sir.
You considered before also. So you have to consider that. I'm pretty sure of that. Please. Jiten.
Sir, Pembro, if CPS is high, if TMB, then probably we can think of Nivo also.
TNB, Nivo, Pembro, if CPS. Where is this coming from?
The date, because Nivo is more correlated to TMB. If
Okay, we'll come to that. Viraj, what is your take now?
Nivo single agent.
Okay. So 059, if you look at it, the progressives were it was around 56%. That's the very thing that struck my mind. But one thing was that the 059 had both PDL1 positive and negatives. But if you break down into positives and negatives, and if you look into that, look at the last line, all the PDL1 positive, the response duration was 16 months versus 6 months. Basically, and 50% of patients were 40% were PDL1 negative. And that drove the data down. How I look into it, if it's a positive patient, I think third line you have data at least to look into and consider this trial. Thus, if you look at the keynote 061, again a Pembro versus Paclitaxel, this is the trial which was negative on its intent. But if you look at it for these patients who were more than equal to 10, the hazards is 0.64. Viraj, are you convinced of this, that in a higher CPS you would be considering and pushing for an immune checkpoint?
Immune checkpoint, yes, not
Yeah.
Pembro.
Okay. Sorry. I know, I spoke, that was for all patients. But if you go down to more than 10, it's down. That's in the red. That was CPS more than 1. But when they put up the subgroup more than 10. So I'm not telling to take home any conclusion. What I'm looking into is the higher the CPS score, probably the benefit will be little larger. All of us expect that. The attraction 2 is something which looked at the Nivo. And here it was for the gastric adenocarcinoma. And that showed a benefit in the OS and the median PFS. Adeno. So now, Vishwajit, can you go back home and think of third line immune checkpoints? Okay. So I think one more person for immune checkpoint third line. Okay. So MS I'm not going. I'm last minute on my panel. Anyone with that experience of dostarlimab? You're or there in the panel. Okay. What struck my attention was the data, which although were nothing for gastric cancer, for GA cancer, when the data for 30 or 40 patients were there with dostarlimab, the responses was around 40-45%. Unlike the responses which we saw in the early rectal cancers. That's one thing that struck my data. That's why NCCN has put up in 2022 one of the preferred option for the PDL1 or CPS positive. I don't know why, but yes, it's now in one of the options which NCCN has put forward. Yeah, 1 minute and I'll close. NTRK gene fusion in GI cancers. Anyone in the house has a experience? Chandil is laughing. You have a trial running, so how many patients? Please, please.
The NTRK phase 2 study we are doing.
Okay.
It's a clinical trial.
Uh-huh.
So there, the first part is the screening. So
Okay.
there are 3 malignancies. Colon, gastric is not included because they have already done. So colon, melanoma, and breast is what screening is going on. And the drug is available for, they opened up the drug for all sites now with NTRK.
Okay.
So we have 1 patient on breast and 1 patient on lung.
Head and neck, you should try because quite a
We
bit of
currently
them
don't
come
have
NTRK
anybody.
positive.
But if you have any patients, you could
Okay.
send for the.
So single was combination. I'll leave that. My last slide. Any other comments in the second or third line? Viraj, starting from you, or we
So immunotherapy irrespective of PDL1 in third line.
immunotherapy
attraction
irrespective of PDL1 in third line, just because you don't
Nivolumab.
just because you don't have options.
Correct.
Okay, that's because of that.
No, and attraction 2 showed irrespective of PDL1 status, there is at least 15%
But did it
of
also
patients
didn't show the more than 5? The benefit was much more pronounced.
in third line.
Yeah, third line.
Of course, so higher the PDL1, better the response, but you don't leave them alone.
Okay, that's it. So from your any take-home message? No, no.
No, sir.
Metronomic chemotherapy. Okay, what would you the protocol be? Same methotrexate and endoxan.
Yeah, you could try that.
Anyone has experience
What we had actually.
in anyone in this with the metronomic in stomach cancer? Yeah, okay. Sure. Single agent? And they were EGFR positive for something? So if it is positive, you would consider that. Okay. Okay.
So,
One more drug.
just to add on, sorry,
Yeah, please,
One more drug, trifluridine tipiracil. So
Yeah.
that is one.
I didn't put it up. That is the approved third line. And one more last thing which I forgot is in the elderly, there are more than one trial in stomach cancer at least, where they reduced the dose to around 40%, means 60% of the dose, and they did not find a decreased benefit. So that is one statement which I want to put forward because stomach cancers, if it's the elderly poor GPS, do not hesitate to reduce the dose. There are more than 2 trials in this which are published, did not have decreased efficacy. The statement is very clear that you can always start with lower dose if you are very skeptical about the tolerability. Dr. Sindhil.
Now, just in addition to what Amit was saying, there is a registry data that is published a couple of months before in JCO
Yeah.
with the addition of anti-EGFR agents to chemotherapy in first line, second line stomach. And the registry data shows that there is actually benefit to the addition of anti-EGFR agents to chemotherapy,
So
not as single agent.
So that would be for
So it
person.
seems to be a driver. It seems to be a driver,
So,
but
so is it for positive patients or?
yes, it's for positive.
Yeah. So
Amplified and mutated.
If it is positive, that's what he told. Okay. So to conclude, I conclude the chemotherapy versus immune checkpoint versus chemotherapy and trastuzumab. It is depending upon the patient selection, HER2 positive, the MSI, and the PDL CPS score, tumor mutation burden, probably in second line, and NTRKs in the second line. The immune checkpoint, first line, there is data that has come up, 811. There is also data from Nivo, if I'm not wrong, for the first line. Yeah. So these two are the data which is there. And the Pembro, the data is only for the HER2 positive. I want to be pretty clear on that part. The second line, PDL1 higher is the better. But for the third line, the panel, some of them believe that they should be offered, and I also strongly believe because nothing is there, that could be one of the things, but higher it is better. The benefit of chemotherapy plus ramucirumab is better than single agent chemo, that's for done case. If it's neuropathy, do not use taxanes. Pre-docetaxel exposed, probably you can do better with FOLFIRI or irinotecan based regimen. That's what small data set is there. And in the third line, it is again immunocheckpoint versus the third line which Vishwajit told. Is it available in India? And we have it. Okay, okay, plus best supportive care. And so that is the 3 things, and that data also showed a decrease in the dose does not matter. So with that, I thank you all. Thank you, panel. Thank you.